Hi guys, very good evening to everybody. And today we'll be doing this image-based session where I'll be handling a couple of questions which are on the pattern of the current examinations that are being conducted by the various boards across the country. Our primary objective would be obviously to focus on the INI-CET exam, and it would be great to hear from you guys again. So if you can just let me know regarding the audio and the visual part, and we can then go ahead with the question for today. Yep. Hi, Prakhar, Dr. Gajendra. Very good evening. Good to see you guys. Yeah, I'm doing great, Gautam. Thank you so much for the kind wishes. And yep, just let me know if the audio visual part is perfect. Hi, Dr. Ankit, Dr. Lakshmi, Dr. Vanna. I had an answer there also, Berlin criteria. So that's good. I like the reflexes. That's what I want. You get a 1 minute for a question. So you should be able to evaluate all the options and obviously read through the text pretty fast. Very good evening to everybody. Okay, okay. Maybe the lighting is too good today. Chalo, great, great. So I had a confirmation regarding the audiovisual part being perfect, and Jay, yes, I'll be conducting a separate session for the FMG students as well. So meanwhile, you need to keep the focus on. That's the only thing that I can say at the moment. I missed a couple of names at the moment. Dr. Vanna, Dr. Harsh, Dr. Patel, Dr. Manzar, Dr. Krishnan. So very good evening. In case I missed a few names, that can happen because the chat goes up pretty fast. Let's focus on the first question for today. We have this 30-year-old patient who presents after falling from a motorbike with chest pain and difficulty in breathing. And the vitals are showing blood pressure of this patient, which is little on the lower side. I'm not comfortable with a value of 100 by 70 millimeter of mercury. The pulse rate is 100. That's pretty decent. But the blood pressure is on the lower side, and the X-ray of the patient, I'm going to zoom it in for your convenience. And while you are looking at this X-ray, you will be able to notice a problem on the left hand side. I think everybody here can see a fracture, which is in fact more than one. So I can say this particular guy has suffered from a flail chest as of now, and would be having some problems, because if I say more, then I think the answer will become very obvious. So what I want from you guys at the moment is, yeah, fracture ribs are present. Yes, I'll just zoom it out a bit. And let's have the diagnosis from you guys at the moment. Yep, there is a flail chest, agreed. I mean, one interpretation that we have made is there's a flail chest. And the question is regarding what is the subsequent manifestation that would be occurring in this patient. So great. I would like it in case you can comment as ABCD so that we can focus on your exclusion capabilities for today. Good evening, Dr. Reformer. Okay, let me rule out one of the options here for you so that you become a little more comfortable. One information that is okay, I got a D there. That's good, Berlin criteria, because what we're thinking is that the flail chest could have resulted in development of pulmonary contusion. And because of this pulmonary contusion, we can then be having is a development of ARDS, that is acute respiratory distress syndrome. And the criteria that are used for diagnosis of acute respiratory distress syndrome is Berlin criteria. But just think logically and tell me, will ARDS develop immediately? Like, this guy has come to the casualty right now with difficulty in breathing. So I agree to the fact that flail chest can contribute to development of, the bottom line is flail chest is going to contribute to pulmonary contusion and can cause a development of ARDS, understandable. But would ARDS be contributing to manifestations immediately? No. So that is why I'm ruling out option number D in this particular case. So good approach. Yes, I did like, the spot on answers that came up. Let's look at C, GERD criteria. GERD criteria is absolutely Roy, you are having a much more faster or much more, I would say, correct input that you're giving. GERD criteria are useful for diagnosis of fat embolism syndrome. And again, fat embolism is caused by cytokines, and cytokines are not going to cause an immediate respiratory distress in a patient. Yes, Vivek, it would be available in my Telegram group and Prepladder as well. So let's not focus on the PDF at the moment. Let's focus at the job at hand. Why is this not a fat embolism syndrome? Because again, fat embolism will take manifestations of at least one. I mean, the manifestations of fat embolism syndrome take at least 1 to 2 days to appear. This question today that I put up before you was to just tell you about the kind of questions that would be coming in the exam. That is, I want you to have capability of, ruling out the options. Okay. So there isn't an obliteration of the left side costophrenic angle. Yes, doctor, because it's slightly a rotated film. So it does look like this. One of the options is, one impression that can come is this is a pleural effusion. This could be a hemothorax. And then the moment we think in terms of hemothorax, then Light's criteria come into the picture. But I think what everybody is missing out, Ashwin came up with option number A, Light's criteria, considering that this is a case of hemothorax. Point is, if there's a hemothorax, why would I be interested in doing a diagnostic tap in this patient right away? If it's obvious, this is a rotated film. What most guys are missing out at the moment is that there is a very clear-cut pneumothorax in this patient. In fact, if you focus on this particular area, you will notice that there is a complete absence of vascular markings. So this particular chap, once he has suffered from fracture of the ribs, because of the fracture of the ribs, there is a development of pneumothorax. And what you need to now do in this particular question is use exclusion capabilities to come out to the answer of this particular question. I'll just highlight the site of pneumothorax that I'm pointing out, which is very close to the area where there is going to be the flail chest occurring in a patient. So hi Aditya, I've ruled out option number I have ruled out option number D in this question, Berlin's criteria, because that is for ARDS. ARDS will take some time to develop. Option number C is also ruled out because it will take some time to develop. The person is having symptoms right now. So either it's going to be A or either it's going to be B, that is Light's criteria versus a Light's index. So the point is, the answer is not A, guys. I think nobody got this one correct for today. Yep, Manzar got this one right. You had to work it out by exclusion. Light's criteria are useful for diagnosis of pleural effusion. But what you have to pick up in this particular case was not that there is any pneumothorax, there is any pleural effusion or there is a hemothorax. What is present in this case is a pneumothorax. And for pneumothorax, we use what is called as Light's index. It's more of a radiology based question. I would say radiology / medicine based question. The correct answer for the first question for today is option number B. And for those of you who could not pick up that Light's index thing, so let me just show you what they mean by the word Light's index. Let me just zoom into this slide, and this will give you orientation about Light's index. Nobody would expect you in radiology to remember this formula, but Light's index basically tells you about estimating the volume of pneumothorax. Because after all, there is air present in the pleural cavity of the patient. So we have a statistical formula available where we are going to take into consideration, we can see the pleural reflection. We can see this would be the ipsilateral collapsed lung in the patient. So we are gonna do some, use a scale and measure the size of the collapsed lung versus the size of the chest. And on the basis of that, we calculate what is called as a Light's index, which is useful for evaluation of pneumothorax in a patient. So the first question that I put up for you guys today was slightly a tricky one, in a sense that all possibilities have to be considered, and that is what happens in the real exam also. That most of the options that you read, at least I can say out of 4 options, 3 options are gonna be like that लगेगा ये भी हो सकता है, ये भी हो सकता है. So you need to keep the possibilities you need to rule out the options by logic. So let me do the logic once again. The moment you read a bike accident, a lot of guys commented regarding fat embolism. So I agree that, every time you're reading about a fracture of a long bone, you have to think in terms of fat embolism. That is not a wrong thought process. But the point is that when it comes to fat embolism, the manifestations do not develop immediately. They take some time to develop in a patient. So same is the case with ARDS. So if you were thinking about C and D in this particular case, yep, it's not that your thought process is wrong. It's just that you have to fine tune your reflexes for the fact that the manifestations will take about 24 to 48, maybe going up to 72 hours to manifest. That's point number 1. So that's how C and D is ruled out. Between A versus B, Light's criteria versus Light's index, I deliberately put up an X-ray which in the exam will, make you think it is a pleural effusion. And that's why a lot of guys commented A also. So if you commented A, don't get disheartened. I'm not calling you out for that. It's just that my objective of conducting this session is to fine tune your reflexes to get to the right answer in the shortest possible time. I agree that, sometimes when you start the paper, initial questions might look like a bouncer and then the motivation level tends to go down, but persistence वही है, हिम्मत वही है ना कि 5 गलत हो गए फिर भी छठा सही करके आ रहे हैं. That is the real thought process. This is the real game. You are doing those questions in spite of the fact that you're getting them wrong. That's all the persistence is all about. So good job, guys. I think I got pretty decent answers for this one. Participation was good, but then the answer was option number B for this one. Slightly a difficult one, yes, to ignite your brain. That is why what I did it. And yep, this is the same X-ray once again. In this X-ray, once again, what I'm showing is I think everybody, even if we are online at the moment, you can notice that there is an abrupt change in the curvature of the ribs. That's because of the fracture of the ribs that is happening. And just below that, this area is relatively devoid of vascular markings. That's where the pneumothorax is coming up. And that is why in this particular case, because there was a pneumothorax, yes, doctor, initially it might look like a bat wing edema, cardiogenic pulmonary edema, but the scenario has to be also, taken into consideration. X-ray alone can never be a diagnostic feature. You need to take this into consideration along with the clinical features. I mean, X-ray is an extension of your clinical examination only. Had this question began by saying that, okay, the chap is having absent breath sounds, the chap is having absent air entry, this would have been a piece of cake for everybody. And then I think the strike rate of most of the people would have been much higher, and strike rate of most people would have been much more superior to what I got right now. But chalta, I mean, one difficult one easy thing would also come. So I mean, just keep the focus, and I'm very sure that you guys are gonna do great. And as far as a couple of people who commented regarding the pleural effusion, yeah, usme wo meniscus sign has to be present, no? That characteristic Ellis curve has to be present. So unless and until you are able to, point out towards the presence of Ellis curve, meniscus sign, this concavity that comes up with pleural effusion, though, I mean, I've shown two demonstrations. One is obviously on the left-hand side of the X-ray, and I mean, the pic that is made is for the pleural effusion on the right-hand side. But then the issue is mainly for pleural effusion. We use Light's criteria, and they help you differentiate between whether it is a transudate versus an exudate. As far as the Light's criteria are concerned, pretty straightforward ones. We don't check out sugar. In fact, if you are FMG student listening to this, then they've asked in your exam for Light's criteria what is not heard. So it's pleural fluid. Sugar, that's not gonna be considered. It's gonna be mainly the presence of proteins and the LDH component. So yes, HPD, thank you so much for the inputs, and let's move on to the second question for today. I just zoom it in for your convenience a bit. Dr. Akhtar, yep, I'll keep on providing inputs. We have subsequent sessions lined up for the FMG exam as well. But try to solve them today. I mean, let's see how it's nothing like ye exam ke question nahi hai iske. It's all about for you it's a case as a doctor, right? So you will just try to solve it. Okay. Moving to question number 2, I have the 60-year-old chap in CCU who's undergone a cabbage coronary artery bypass grafting. He was given a blood transfusion, and now he's having a breathing difficulty. The moment he's having a breathing difficulty, a couple of differentials will come up or will originate in my mind, and they are also on the board. And then in this particular chap, you are also noticing that the pH of the patient is 7.5. So I can notice that there is a alkalosis also occurring in this patient. And I mean, I'm getting multiple inputs. I got a B, I got a C. Yep. So I think most of the guys are getting this one pretty clear. This was relatively a much more easier one. You see, the pH of the patient is 7.5, but at the same time, you will notice that the PCO2 of the patient is less. If PCO2 of the patient is less, it tells you that the person is having respiratory alkalosis. This is because of the hyperventilation due to whatever reason that he's having. The ABG report of this patient would be answered by you as uncompensated respiratory alkalosis. Because I wrote uncompensated respiratory alkalosis, I can therefore say that option number A can be ruled out. I mean, A said metabolic alkalosis. For metabolic alkalosis, bicarbonate should be elevated. So option A is out of the window. Mismatched blood transfusion has to be kept, but then features of mismatched blood transfusion would also involve development of fever, development of hypotension, development of a rash, flank pain developing in a patient. None of those classical features that we read with respect to rash or flank pain are given. So option number D is also ruled out. So you're left between Trali versus TACO. I think the simplest way to solve this question is because he's himself saying CCU may patient he's undergone a CABG, so that means that there has to be a cardiac reason. His heart is already weak. The patient's heart is already weak. And once you are given a blood transfusion, maybe more than one, or maybe the blood transfusion went very fast, and because the guy is having a ischemic cardiomyopathy because he underwent a coronary artery bypass grafting very late, he went into heart failure. And another very, very good hint that I want you to pick up in this question is the fact, the very clear characteristic feature which is present is that the PCWP of the patient is 25 millimeters of mercury. Whenever you read a PCWP of 25 millimeters of mercury, that's going to be exceptionally high. I mean, this tells you that there is a cardiogenic pulmonary edema. Normal PCWP कितना होता है जरा chat में लिखो यार फटाफट से. Can I have a quick input from you guys with respect to, I mean, what is gonna be, or what is the standard value? What is the standard value of normal pulmonary capillary wedge pressure? The normal pulmonary capillary wedge pressure oscillates between 8 to 12 millimeters of mercury. Exactly right. I mean, most guys are answering so spot on. You know, the normal PCWP values are going to be 8 to 12 millimeters of mercury. In this particular case, you are getting a doubling of PCWP. Because you're getting a doubling, that again highlights this fact that the patient of mine is suffering from cardiogenic pulmonary edema. And when I say cardiogenic pulmonary edema, he is a known case of ischemic cardiomyopathy. How I know that? Because he underwent a coronary artery bypass grafting. Anybody having a triple vessel disease is a candidate for undergoing a CABG. In a person with a weak heart, when you give a blood transfusion fast, it's going to contribute to a TACO. So the correct answer for this question is C, that is transfusion associated circulatory overload. And a lot of guys mentioned TRALI here as well. Guys, TRALI is one non-cardiogenic, and one of the diagnostic criteria non-cardiogenic pulmonary edema is that PCWP will be normal. I repeat that again. How do you differentiate between TRALI and TACO? I mean, I think a couple of guys made errors there as well. So I'll just dedicate one more slide to this. Let me just quickly explain this, guys. Very simple, very straightforward data. I mean, you are going to get questions always in the exam post blood transfusion between TRALI versus TACO. And the simple hack to solve this is, one, look at the blood pressure values. Blood pressure values are either going to be normal or can be lower in TRALI, but in transfusion associated circulatory overloading of the heart, so BP of the patient will always be elevated. Apart from this, because heart will fail, so JVP values will rise. Because the left side of the heart will fail, because the right side will fail, JVP will rise. Because the left side will fail, PCWP will rise. Pulmonary capillary wedge pressure is going to show a dramatic rise. And that is what was present here, almost a doubling that is happening here. More importantly, we can also check out, yes, you are right, Dr. Keswani, that we can get within 6 hours TRALI. That's exactly right. But the point is, how do you differentiate? The differentiating features are, for TRALI, there will be no mention of changes in the JVP. There would be no mention of the changes of the PCWP, and the BNP levels in the patient will be normal. So the basic concept is that when it comes to transfusion associated circulatory overload, this is going to be an example of cardiogenic pulmonary edema in a patient, whereas TRALI is always going to be non-cardiogenic. And if you find this too hard to remember, then I can say the clue was present in the first line of the MCQ itself. Let me just change the slide and go back to the original slide so that it will become relatively simpler for you to pick up. Because that classical bat wing edema, you know, if I try to, you know, waste my time in the exam here, in the X-ray trying to find out, is it a bat wing pulmonary edema? Is it not a bat wing pulmonary edema? That is gonna eat up a lot of my time. So I'll focus on the metrics. I'll focus on the mathematical inputs which are given to me in the question. So let's read this question once again, and we'll have a final conclusion. The correct answer for this question is option number C. Let me read it out once again. The visual cue here is a patient is in CCU post cabbage. And this means, I mean, why do you do a cabbage, right? Person had a triple vessel disease and might have had suffered from ischemic cardiomyopathy. So the heart is already weak. You gave a blood transfusion. Now you did give 2 or 3 units of blood or packed RBCs. 1 unit given fast, the heart is decompensating. And then the biggest, I would say the biggest solution is the biggest hack which is present in this question to solve it is the value of pulmonary capillary wedge pressure. CVP of this patient is fine. That's to the normal CVP is central venous pressure is 2 to 6 centimeter of water. So iska CVP to normal hai. इसका central venous pressure normal है, but what is elevated is pulmonary capillary wedge pressure. PCWP deals with the left side of the heart. Every time the left side of the heart will decompensate, pulmonary capillary blood pressure is gonna shoot up. Yep, we are gonna give, we have to, in this case, I mean, the volume overloading has already occurred, so we need to stop transfusion, give furosemide to this particular case. The main differentiating feature between option number B and option number C in this question is the value of pulmonary capillary wedge pressure. Option number A I've already ruled out because there was no metabolic alkalosis. क्योंकि अगर metabolic alkalosis होता, then the value of bicarbonate in the patient would have been elevated. In this particular case, the value of bicarbonate is given to be normal because this is an uncompensated respiratory alkalosis. Is hyperventilating. भाई अगर उसको हार्ट फेलियर होगा तो हार्ट फेलियर पेशेंट इज गोना हाइपरवेंटिलेट. हाइपरवेंटिलेशन will cause the carbon dioxide washout, which is why in this guy the PCO2 of the patient is 30 millimeter of mercury instead of 35 to 45. It's 30 because any heart failure patient will be hyperventilating. So this particular chap at the moment is having a respiratory alkalosis, not a metabolic alkalosis, which is a known complication of blood transfusion post cytotoxicity, but is mainly seen with massive transfusions. It's unlikely to be seen with 1 unit of blood that we start getting a citrate toxicity unless and until the technician has really messed up and the additive solution has been added in a very large amount. Usually the quality control in the blood bank is going to be such that the amount of additive solution added to the unit of blood is going to be strictly regulated. But yep, I mean, that problem can occur, that if quality control is not there, the person might end up with metabolic alkalosis as well. Okay, Doc. Let's just focus on the questions at the moment, and I'm done with question number 2. That would be taco and not a trolley. That's a hack to solve it. I mean, any person with weak heart, blood transfusion, you have to think in terms of taco, and then the pointers which are given in the question. And then we come to the straightforward one, which is a hot favorite of these INI-CET people, that they love to incorporate a question on a CT head with person having standard features of stroke. So let's check out your reflexes. In this case, we have a 70-year-old man, and he's having features of facial asymmetry, arm weakness since last 4 hours. So I can say this is looking like a MCA territory stroke in a patient at the moment, because there is a facial weakness, arm weakness occurring. And he's underwent a colon surgery previously. Pulse rate is 100. That's decent. BP of the patient is 160 by 100 millimeters of mercury. So I mean, thrombolysis would not be contraindicated because that's usually 185 by 110. Temperature is normal. Patient can maintain his airway. That's good. Respiratory rate is 15. That's pretty decent, and which will be best for this patient. So one, I think everybody is very clear about this fact that this patient is not having a hemorrhagic stroke. I'll zoom into this image here, and on one side you can see the insular cortex. I think you can see that insular ribbon. But on the contralateral side, you can notice that that insular cortex is not very clearly visible. So the radiological sign that I'm trying to show in this particular image, I'll just use a different color to highlight that. The radiological finding present in this case is that of loss of insular ribbon. That's one of the features that I have highlighted. I would like you to compare where I put the arrow at the moment. You can see the area where the insula is located, and compare that with the contralateral side. So because of the loss of insular ribbon, the clinical diagnosis of this patient is acute ischemic stroke. Even if you read the CT as a normal, doesn't matter, but still it's gonna be clinically a ischemic stroke, because hemorrhagic stroke manifestations develop very fast in a CT scan. Hemorrhagic stroke manifestations will appear very fast on a CT scan, but ischemic stroke findings take some time to appear. So if you could pick up the ischemic stroke on the left hand side, I'll just put a pointer there. This person is having a left-sided AIS. This person is having a MCA territory left ischemic stroke. Yes, guys. So let's look at what people have answered. I've got a A, I've got a B, I've got a D also. So whole lot of choices coming up. Let's start with option number A. Can I do thrombolysis in a patient because he's having weakness for last 4 hours? Definitely on. Thrombolysis can be done within 4.5 hours. So this obviously can be the answer to my question. I just put a plus here because let's not rush into the answers. Lowering of blood pressure is not required in this case. So I'm ruling out option number B, because we know that the cutoff for lowering of blood pressure is 185 by 110 millimeter of mercury. When we look at C, thrombectomy, you see the patient, why I'm considering thrombectomy is because patient underwent a big surgery. patient underwent a colon surgery. He could be having maybe a colon cancer, or it's not specified what kind of a colon surgery. But if a person has undergone a colon surgery, then we would not be comfortable doing thrombolysis. So even thrombectomy has to be taken into consideration. And I would not like to give a loading dose of aspirin and statin right now, because I need to do an intervention in the patient, and later on I can give aspirin for secondary prophylaxis. Statins can be given to a patient. So I mean, why am I, not talking about option number D in this question is one, this would be given in a case of TIA, or it can even be given in a case of stroke, but after ischemic stroke, after 24 hours of admission in a patient of acute ischemic stroke, you can be giving aspirin, statin, because now at the moment you need to do intervention. Guys, the answer to this question is not option number A, thrombolysis, because he's had a major surgery. Major surgery is a contraindication for doing thrombolysis. So let me just make you revise the contraindications for thrombolysis. And I think that you have, just glossed over that fact that the patient had undergone a major surgery, which is a problematic issue. Now, as far as the contraindications for thrombolysis are concerned, I'll just mention a mnemonic here. Alphabet S would be easier for all of you to remember. Sustained BP. If the patient's sustained blood pressure values are more than 185 by 110 despite medical treatment, then you need to hold thrombolysis in a patient. Then in this particular case, the second aspect, or the second contraindication of thrombolysis would be from alphabet T, and that would be bleeding diathesis. So what I'm doing here is just making you revise those contraindications for thrombolysis. S is for, the answer for this question is going to be answered as thrombectomy. That is option number C. Let's just quickly revise this and I'll come back to why the answer is there. Then, I mean, any person, whenever you read about this, you always read like this: major surgery. Definition of any major surgery is any surgical procedure done for a duration more than 90 minutes. Major surgery could be a GI surgery, colon cancer surgery. In those particular patients, we would not like to go ahead with thrombolysis in a patient. Then is if a person has had a recent myocardial infarction, or for that matter of fact, if he has had a recent MI. In fact, before that, I can say if a person has had a recent, recent stroke or intraparenchymal hemorrhage, that's again a contraindication. Recent MI is also contraindication. So when you go through the contraindications for thrombolysis, you have to remember the ones which I mentioned, including ones like, recent stroke, intraparenchymal hemorrhage, recent myocardial infarction. So the STOR mnemonic you can remember like this: S would be for sustained elevation, then is diathesis, then is for major surgery, then is for recent coming up, recent stroke, recent myocardial infarction. But these are contraindications which are to be remembered for doing thrombolysis in a patient. If I come back to the original slide, I'll just make you go through the question once again. We had a 70-year-old patient with features of MCA territory stroke. Is it a hemorrhagic stroke? No, because I cannot see a hypertensity. So I'm assuming this would be a feature of acute ischemic stroke. And it's not that I'm assuming, it's a clinical diagnosis, because lots of time the features of stroke will take some time to appear, which is why we ideally prefer to go ahead with a CT angiography. You anywhere aware of that previous year question that if a CT is normal, what investigation would you be doing subsequently in a patient? You will be doing a CT angiography in a person. But anyway, in this particular question, there was a finding. The finding that was present was loss of insular ribbon, which is again going in favor of ischemic stroke. But what you had to pick up was that the chap is having a colon surgery. That's a major surgery. Definition of major surgery is any procedure done for a duration more than 90 minutes. We would not like to go ahead with thrombolysis in this patient. The correct answer for this particular question is option number C. Slightly a difficult one as compared to the previous one. So if I take out of 3 questions that we have discussed till now, 2 were, I would say, a little tricky ones. One was relatively a simpler one. So that is what is gonna be the usual pattern in the exam. It's a roller coaster ride. For one right, you can get 2 wrong, and then maybe you get 3 correct, then you get maybe 1 wrong. So you have to be very consistent. But then in the final scores are obviously dependent on your presence of mind to be kept in the exam. वो game सारा वो 3 घंटे का ही है. तो वो in that 3 hours, how would you be able to perform is based on what you're doing today. And what you're doing today is not only to be done in a live session. You have to do this regularly. I want you to go through the previous year discussions. I want you to listen to the previous year discussions available on my channel or this channel or wherever. But like I put up the medicine ones also. why it is advantageous to listen to them and just not just go through the questions is because you tend to learn exclusion capabilities. I mean, that is what is of paramount importance. So the correct answer for question number 3 for today is option number C. This was acute ischemic stroke, contraindication for thrombolysis was present. And let's move on to the fourth one for today. I think it's running very well on my side. Okay, you can just refresh. I'm looking weak. Okay. Fine. Obese नहीं होना चाहिए. चलो जी. The question says identify the sleep cycle in the following polysomnography, and I think because the image would be smaller, doctor, you can mail me at marvamedicine@gmail.com. It would be difficult to provide the Telegram link here. Haha. Very good, very good. Most guys are getting it spot on, right? You can see the EEG of the patient, but as I've told, don't try to be, Sherlock Holmes and try to decipher the EEG of a patient straight away. Look at the EMG of the patient. Whenever they give you EEG of a patient, you must always look at EMG. And the moment you look at the EMG, there is hardly any movement occurring. Because there's hardly any movement occurring, that means that the person is muscle tone is less. The phase of sleep in which the muscle tone is less is REM, and that is where we get those sawtooth waves present. So yep, I mean, we can get into the technicals also, but then this is a basic hack that I have provided even in the rapid revision series, and this is what I would like you to remember, that when you progress through the various stages, I think the easiest one that is to be picked up is if you compare the EMG in a awake state versus EMG of the chin or of any extremity, you will notice a decrease in the muscle activity, because REM sleep is when the muscle tone would be relatively the least. So whenever they give you a EEG, instead of trying to pick up those sleep spindles or trying to pick up those delta waves, like obviously we can pick up the delta wave relatively easier, because on a comparison basis, if you look at it, if they give you a comparison, it is a piece of cake. No, delta will have the highest amplitude and the slowest velocity. The slowest frequency. I mean, delta wave frequency is going to be only between 0.5 to 4 hertz. So if you compare the frequency as compared to the superior ones, you can notice the frequency is slower, but they have the highest amplitude. But in an isolation, it would be a little more difficult. So Madan, my advice to you would be go to the rapid revision part, in which I've tried to focus on the various EEG waves, normal frequencies and normal frequencies. And this diagram, if you keep a mental image of this in your mind, it would be spot on. And anyway, anytime they give you a question like this, what you're supposed to do is don't go into counting the waves or into the frequency. Don't try to check out the pattern of sleep spindles, though I've explained that in my main videos, the sleep spindles as well. What I want you to do is look at the EMG. If the EMG of the patient is showing very minimal activity, as was in this particular representation, that is where you can see that he will give you a highlighted section. Even if you go through the previous year questions of INI-CET, they have always given a highlighted segment, and in that only they have asked, okay, what is the wave that is present? So that's going to be anyway REM phase. So most guys were able to get this correct. Meningococcus, Ashish, Rakesh, Shri, great. So Sabji, enough, there is nothing like enough in medical field, enough to Harrison भी नहीं है. आप आदमी Harrison पढ़ के भी मतलब somebody can flunk an exam. तो इनफ कुछ नहीं होता, पर इतना कर लो तो एटलीस्ट यू गेट इनटू दैट बैटल मोड कि हाँ यार, आई एम एबल टू एनालाइज द डेटा. Otherwise there's nothing enough in our field. I mean, you can keep on reading whole life. Okay, let's move on to the fifth one for today, in which they give you situations like these. I'll just zoom into the image. PCG is phonocardiogram, and then is ECG, and he said S2 जो है second heart sound he is asked is with corresponding to which of the following. Okay. Yeah, Sanchit, we can do that. We can go ahead with the EOG component as well. But I think that absence of activity as compared to picking up high activity is much more easier to pick up, right? I say that again. In EMG, the muscle activity, in fact, I can say another way, since Sanchit put up that point, compare the EOG and the EMG, and there's a huge disparity. Max disparity will be seen in the REM phase, because EOG is going to be going crazy, and EMG is going to be going literally towards the baseline. So if I modify what you Sanchit said, I can say huge disparity between the EOG, EMG, again tells you this is REM phase. Okay guys, let's have a look at the data here. And this is ECG versus the PCG, the phonocardiogram, where the heart sounds would be present. So if I just look at option number A here, the option number A would be corresponding to the QRS complex. QRS complex is going to be the time when the heart is going to be contracting, and when the heart is going to be contracting. So I can say at this particular point in time, I anticipate that the heart sound that would be present in a patient, because when I say the word contraction, contraction means aortic and pulmonic valves are opening. And when aortic and pulmonic valves are opening, the sound that is produced is called as ejection click. फिर से करते हैं. I'll just zoom it in even further for your convenience. Yep, I think now it is better. A से आप vertical line draw करो तो it is corresponding to QRS complex. QRS means ventricles are contracting. Contraction of the ventricles means aortic and pulmonic valves are opening. And if aortic and pulmonic valve is opening in a patient, then it cannot be S2, because S2 is gonna be the closure of the aortic and the pulmonic valves. Now I wanted to look at point number B. Point number B is corresponding to, I'll just draw a vertical arrow. It is just going towards the end of the T wave. End of the T wave is the time when the heart is relaxing. That means contraction is over. And when the contraction is over, that means now the aortic and pulmonic valves will close. So therefore, this is the time, guys. Point number B is the time. I'll use a different pointer to highlight this. That point number B is the time when the T wave is over, the heart is in a relaxation mode. And the moment I say relaxation mode, that means that now the heart has done its job. The job of the heart is to send blood into aorta and pulmonary artery, 80 ml on both sides. Once the heart has done its job, the aortic and the pulmonic valve will close, and the closure of the aortic and pulmonic valve is second heart sound. And then if you look at point number C is corresponding to the P wave. It is bang in the middle of the P wave. And what does P wave indicate? P wave indicates rather atrial systole. So if he had specified, I mean, what does point number C in phonocardiogram here indicate? Then point number C indicates atrial systole, whereas point number B is indicating end of ventricular systole. In fact, I can put it like this. This period between A versus B, this is A is S1 and B is S2. The period between S1 and S2 is systole. No? The only thing that you have to do in this particular question was to just pick up that, okay, why? I mean, I think everybody could have ruled out option number C, because C is corresponding to P wave and P wave is atrial systole. तो उतना तो clear हो जाता है यार कि it cannot be S2. तो बच गया था ए वर्सेस बी, बिकॉज ऑप्शन देखो डेटा इनसफिशिएंट, तो मतलब ऐसा तो कोई आउटरेजियस क्वेश्चन नहीं देगा कि जिसमें डेटा ही नहीं होगा. आई थिंक यप, नाउ इट्स इन फोकस. So I think data insufficient is an option that can be ruled out easily. You have to select between A versus B. And for A versus B, I'll zoom it once again for your convenience in case you are just joined the discussion. At A, it is QRS complex. QRS complex is when the heart is contracting. When this contracting, the aortic and pulmonic valve will open, and opening is not second heart sound. So immediately you know answer is not C. Why? Because that is atrial systole. Answer is not gonna be A, because that is gonna be corresponding to ejection click. The aortic and pulmonic valves would be opening. So the correct answer for this would be option number Bombay. Yep, I think most guys got this one correct. So good job guys. Omkar, Diksha, Dr. Vanna. I think most guys have got this one right. Okay, cool. So I think this kind of data is also discussed in physiology. So I am really happy that you were able to score this one correct. Let's move ahead. A couple of spot on questions here. CT chest of a patient is shown, and you can notice grossly dilated airways. I think I made the diagnosis. Lakshmi says, where is S1? S1 is gonna be just before the ejection click, right? So if you go through the venous diagram, then it would be right at where the QRS complex would be starting. That's where the first heart sound would be coming up. Okay, so I think I'm getting a correct spot on answer for the subsequent one, which is a spot diagnosis. Everybody can pick up those thick dilated airways. The closest option for this would have been pneumatoceles, but then the point against pneumatoceles would be that pneumatoceles will not have a very thick wall. Pneumatoceles are normally read by you with respect to Staph aureus pneumonia, but to have so many of pneumatoceles together is very unlikely, and they do not have a thick wall as is highlighted in this particular case. So the correct answer for this one would be option number A, that is bronchiectasis. Mithu, for signet ring, no, you need comparison with blood vessel. The airway and the blood vessel in comparison then have to be taken for a signet ring appearance. So here I can just say I can see some cylindrical dilatations with thickened airways, which is why the answer goes in favor of bronchiectasis. Loculated empyema, again, I mean, for empyema there would always be septations present. So there would be some focal collection and there would be some septations present. And this is anyway not a normal scan, so pretty easy one that I put up for the current one. So great. Yes, the correct answer for question number 6 is option number A, big dilated airways with thickened airways. Let's look at the next one. The impressions are a very outrageous one. Both lung fields in a CT chest again. And you can see this huge bullas, which are air-filled dilatations. I mean, this guy, इसने तो cigarette पी के अपने lungs को इतना damage कर लिया. These bullas can rupture any time, and this guy can even end up with development of a spontaneous pneumothorax. In fact, when I looked at this image initially, I thought, I mean, any doctor, if he looks at this image initially, it will look like this could be a pneumothorax. But then to have a pneumothorax on both the sides would be a little unlikely. This is, I got a D also. Pneumo ultra microscopic silicovolcanosis. ये क्या होता है यार? Yes, the correct answer for this one is option number A. What is pneumo ultra microscopic? शायद मैंने किसी वीडियो में बताया है, but still, you know. Yes, guys, what is pneumo ultra microscopic silicovolcanosis? पता है आपको? This is the longest word in English literature. It is 45 letters. I mean, when you write a diagnosis like this, no, pneumo ultra microscopic silicovolcanosis, sir, this is the older name for silicosis. Pneumo ultra microscopic silico. This is the longest English word, longest word in English literature. It is 45 alphabets. है ना? This is the older name for silicosis, man. So silicosis में जो finding आएगी वो तो mostly would be snowstorm. And along with that, even hilar lymphadenopathy can be present. Pulmonary alveolar proteinosis, sir, that is wanna be crazy payment. No? So the appearance when it comes to PAP, pulmonary alveolar proteinosis, क्या होता है? The turnover of the surfactant is lesser. Surfactant is produced in our airways, then it is destroyed, and if it is not going to be destroyed, it will keep on accumulating. So PAP is pulmonary alveolar proteinosis. It is because of a defective turnover of the surfactant. The surfactant keeps on accumulating, and yes, Roy, you're right. And thanks for the inputs. Crazy pavement pattern is seen. It is because of the decreased turnover of the surfactant. And in fact, I can say that pulmonary alveolar proteinosis also contributes to a snowstorm appearance. This would not be an artifact if it is so gross. These are large bullas in the lungs which are present because of emphysema, and the complication that will occur in this patient is spontaneous pneumothorax, which would be life-threatening. He can give you a CT like this. He can say what will be the common complication of this patient. Then the most common complication that develops in these patients would be cor pulmonale. Cor pulmonale would mean hypoxia will cause pulmonary artery hypertension and a right ventricular overload in a patient. Arun, it may not be always that in PAP we will have a neonatal death. Patients can go up to adult age group and a person will present with chunky gelatinous mucus plugs. The keyword in the question would be, I discussed that in PAP topic. It would be chunky gelatinous mucus plugs present, which help in diagnosis of pulmonary alveolar proteinosis. How to manage a sudden bulla rupture? A doctor will first have to estimate what is the volume of pneumothorax that is occurred in a patient. If it is a small pneumothorax, don't treat, I mean, monitor the patient, give supplemental oxygen. And if it is a large pneumothorax, if it's more than 50%, you will have to do a needle aspiration, not a wide bore needle. I'm not talking about tension pneumothorax where you put a wide bore needle in the fifth intercostal space, second intercostal space. That is putting up a needle thoracostomy. In this particular case, it's gonna be primarily, the initial approach is mainly gonna be conservative, no, that is oxygen. If it is a large pneumothorax, we can be then in those circumstances be doing a needle aspiration in a patient. And another approach is if it is causing cyanosis, spontaneous pneumothorax, then we can go in for a chest tube also. Listen to the pneumothorax discussion. This is not needle thoracostomy. No, guys, it's not a needle thoracostomy. It's a needle aspiration. You'll use a 50 ml syringe and you will suck out the air in case pneumothorax is causing problems in a patient in the form of a breathing difficulty. And it's not a needle thoracostomy. We're not talking about a wide bore needle for spontaneous pneumothorax. For tension pneumothorax, it's a needle thoracostomy. Put in the fifth intercostal space. That's an emergency scenario. And how would you pick it up? Rudransh, that was Dr. Rudransh put up this question, how to differentiate large versus a small pneumothorax. That was the very first question that I discussed today. So I'll just quickly go back to the first slide, and because I've discussed that with people already, sir, we have what is called as a Lights index, and this Lights index can help us calculate the percentage of pneumothorax. It can be 25%, 25 to 50%, more than 50%, like that. So like you read Light's criteria, no, for pleural effusion. Like you have Light's criteria for pleural effusion, you have Light's index for pneumothorax, that helps you estimate the amount of volume of pneumothorax, whether it's a small versus the large one. Anything less than 15% would be called as a small pneumothorax and would not contribute to too much of problems in a patient. Okay, guys, so I think I have answered Rudransh there. And yes, let's focus on the subsequent question. So we're done with question number 7. That was huge bullahs present in a person who's probably a cigarette smoker, though history was not given. Yes, Aditya, you're right. We'll go ahead with the needle aspiration, and if required, a chest tube. That's only if there's a cyanosis present in the patient. Okay, tracheal shift is not very a reliable feature, but yep, in tension pneumothorax, it goes always the opposite way. Moving on to question number 8, we have the smoker. He came to the emergency department with complaints of retrosternal chest pain for 8 hours. The ECG of the patient is shown, and he says what is correct about this patient. And let me just zoom into the ECG of this patient at the moment. So the heart rate is pretty decent, about 100 per minute. I cannot comment on the axis at the moment, primarily because the data for lead number 1 in AVF is not given in this case. I can notice very characteristic T-wave inversions in the lateral leads as well as in the precordial leads. In fact, all the leads are having a very predominant T-wave inversion. And along with that, I can also notice a very characteristic ST segment elevation, that Pardee sign that I always talk about. That ST elevation is present, the green, where I put up the green marker there. So there is a STEMI also occurring in this patient. This ST elevation is present in lead number V3, V4, V5, and V6. So I think it's more of a anterolateral myocardial infarction occurring in a person. And he says which of the following would be correct about this patient. So can I have the answers in this case? I mean, the blood vessel that would be involved in this patient is left circumflex artery, and the distal part of left anterior descending artery is where the thrombus is going to be likely to be present. Yep. In any patient of ST elevation MI, we'll always go ahead with, I had very good answers there. We'll go ahead with the PCI, a percutaneous coronary intervention in a patient. And yep, I got B as an answer, which is this option number B is a distraction, because window period for stroke is 4.5 hours, and window period for thrombolysis, it's not B, guys, it's not B. What is the window period for thrombolysis? For people saying B, guys, this is not a question of stroke. This is the question of MI. That's point number 1. Point number 2, I mean, within how much time can you thrombolyze? Yes, guys, 3 hours, 6 hours, 9 hours, 12 hours. Absolutely, it is 12 hours. The patient is not, that statement is a wrong statement. That statement is a wrong statement. Patient is out of the window period for IV thrombolysis. IV thrombolysis in this patient can also be done. It is a huge 12 hours, no? So, दो ही तो window period याद करना होता है ना? One, you need to remember window period for myocardial infarction. Second, you need to remember window period for acute ischemic stroke. For myocardial infarction, you can do thrombolysis after 12 hours, up to 12 hours. But we usually do not straight away go ahead with thrombolysis wherever a PCI facility is available. And for acute ischemic stroke in a patient, Urmi says why T-wave is inverted. Okay, Urmi, I'll just explain that. In acute ischemic stroke, the cutoff is 4.5 hours. Now, what is the reason for this T-wave inversion, guys? That's a very severe myocardial ischemia. T-wave is always positive. When does it turn negative? T-wave turns negative either in electrolyte imbalance or it turns in cases of myocardial ischemia. If you go through the ECG findings of MI, the temporal elevation will be like that. You would get initially hyperacute T waves, then you start getting T wave inversion. That's again a feature of both of them. Hyperacute T waves and T wave inversion both indicate myocardial ischemia. And then you have ST elevation, which is myocardial injury. There's a difference between the word ischemia and injury. No, injury होता है तो ST elevation आ जाता है. If mentioned next best step, sir, we'll still answer percutaneous coronary intervention as the treatment of choice for any patient who's having a ST elevation MI. That would be the best treatment. When will thrombolysis be the answer? Doc, MA, welcome to the discussion. Thrombolysis would be answer in case PCI facility is not available. Like he says, patient went to a non-cath lab equipped hospital. Only then. If PCI is not in the options, then it is thrombolysis, which is to be answered. Thrombolysis is done only in case of ST elevation MI. It's not done in non-ST elevation MI. It's not done in cases of unstable angina. PCI should be done within 90 minutes. No, Saksham, that's a different concept. That is door to जब पेशेंट आ गया ना, ये विंडो पीरियड जो है ये सिम्टम से है. जो विंडो पीरियड का कॉन्सेप्ट होता है वो होता है सिम्टम से. और ये आपने जो बोला सक्शन, दैट इज द कॉन्सेप्ट फ्रॉम पेशेंट केम टू द हॉस्पिटल राइट नाउ. Within 90 minutes I should be doing PCI in a patient. That is door to balloon time is 90 minutes. The concept is that we want to give good medical care. We want to do a fast action, that we take a femoral or a radial access, preferably a radial access, go into that artery, heart का जो artery blocked है, and वहाँ पे balloon deployment कर देंगे. So balloon angioplasty should be done within 90 minutes of arrival of the patient to the hospital. पर patient कब तक आए, तो उस पर तो कोई हमारा कंट्रोल नहीं है ना. पेशेंट कैन कम एट एनी पॉइंट ऑफ टाइम. PCI can be done very safely up to 24 hours. Most hospitals would prefer to do it earlier. लेकिन दो अलग अलग कॉन्सेप्ट है सर. वन इज डोर टू balloon time, that is when patient has come into the hospital. That is totally different from the concept कि इसको सिम्टम कब स्टार्ट हुए. हम यहाँ पे विंडो पीरियड की बात कर रहे हैं ना, वो सिम्टम्स है कि सुबह 8 बजे उसको चेस्ट पेन हुआ, तो आप रात के 8 बजे तक थ्रोम्बोलाइसिस कर सकते हो. मान लो यू आर प्रैक्टिसिंग फार अवे फ्रॉम दिल्ली से बाहर गाँव 100 किलोमीटर आगे चले जाओ, एक छोटे टाउन में, टायर 2 सिटी में, और वहाँ पे कैथ लैब की फैसिलिटी नहीं है, एम्बुलेंस से भेजने में टाइम लगेगा, तो हम फिर वहाँ पे थ्रोम्बोलाइसिस कर लेंगे. तो ओनली इन एसटी एलिवेशन, मायोकार्डियल इंफार्क्शन, एंड यस यू राइट, डोर टू निडल टाइम, इमॉन बैनर्जी, यू परफेक्टली राइट, द डोर टू निडल टाइम वुड बी केप्ट अंडर 30 minutes. That's the deadline from the entry into the hospital. So window period concept is totally out of the league for that. So in case you had any confusions for that, my request is just go through the main video once again at 2x, and I think you'll be able to clear that. Okay guys, we are sorted for this one. Let's move on to the next question for today. He says all are correct about the reflex being elicited except, so I put up 2 questions on reflexes because they've been asked in INI-CET. One is a new one and one is a repeat. This is the new one and the repeat one will be done subsequently. भूपेंद्र राठौर, इसके बाद मेरा जो अगला सेशन होगा वो FMG का ही होगा. Okay guys, so he says all of the following are correct about the reflex being elicited except we are testing the abdominal reflexes in a patient. Exaggerated abdominal reflexes can be seen. Yes, I'm waiting for answers. Exaggerated abdominal reflexes can be seen in psychoneurosis. Any patient who's who's anxious, we can be getting exaggerated reflexes. So A looks okay. B says repeated pregnancies can lead to absent abdominal reflex. You see, after repeated pregnancy, the abdominal wall muscle tone will be less because of repeated stretching. So even B looks okay to me because repeated pregnancies will cause a flabby, loose anterior abdominal wall in a lady, and therefore the reflexes can be absent. So the trick is between either option number C or D. Root value of upper abdomen is T7 to T9, and then his Beaver sign is caudal. Caudal means downward movement of the umbilicus on attempting to flex the neck. Let's look at the root values. Let's look at the dermatomes here. So anyway, you know umbilicus is T10. If you know umbilicus is T10, then you very well, if umbilicus is gonna be T10, then if I talk about above umbilicus, it's gonna be T7 to T9. So that means my option number C is also correct here. Beaver sign क्या होता है कि if there is gonna be a weakness of the lower abdominal wall of a patient, if there is damage to T11, T12, and a person is having weakness of the muscles here, then when you will ask the patient to flex his neck, the umbilicus will move upwards. Shocking, no? Umbilicus moving upwards from its position when you ask a person to flex his neck. That's what is Beaver sign is all about. It is a reflex that is elicited in case there is a weakness it's a reflex that is elicited in case there is going to be a weakness of the lower abdominal wall. It's a cephalad movement. It is not a caudal movement. So that is the catch in the question here. And the correct answer for question number 9 is option number D. So I have the right to put up a question which is different from the easier one. That was the previous one. Previous one was a PYQ. This I introduced a new one. So it's going to be a mixed bag as it happens in the actual paper. Yes, doctor. In fact, you will notice, yes, Devesh, you're perfectly right. And you will notice another trick coming up because I'll show you a different question. which has come in the AIMS exam. I mean, INI-CET was formerly called as AIMS. So I'll just move on to that question first, and we'll come back to the ones intervening. Just let me see if I can just find that question. Yep. This is a repeat question from the, I mean, INI-CET was earlier called as AIMS. So let's attempt this one, and then I'll come back to, I skipped a couple of slides because I just wanted to do both these questions on reflexes that have been asked. The question says, which of the following statements is correct? Previous one was, which of the following is a wrong statement? This time he's saying, which is correct about the test being performed on a patient? You can see that the doctor is performing a knee jerk in a patient. The root value of the knee jerk is L2, L3, L4. Here it is written L1, 2, 3. It is 2, 3, 4. So that is why I'm ruling out option number D. The reflex is always absent in case of a peripheral nerve disease. You see, if you have a partial demyelination, reflexes might be present. There might be hyporeflexia. Why I am saying that C does not look right to me is because of the fact that we also have hyporeflexia. I mean, it may not be areflexia. Reflex is always brisk in case of motor neuron disease. The point is, motor neuron disease can be having lower motor as well as upper motor features. You could be having amyotrophic lateral sclerosis. You could be having a spinomuscular atrophy. So if it's gonna be a spinomuscular atrophy developing, then it would be, yes, Aniket, that is what I have told in the rapid revision, that the benefit can be seen up to 6 hours. Option number A, guys, is again a wrong statement because he's saying reflex is always brisk in a case of motor neuron disease. It is not always the case because motor neuron disease can have a lower motor neuron version as well as a upper motor neuron version. The main problem in this particular case is that the test is not being done properly, because when the doctor is doing this reflex, you are noticing that the thigh of the patient is not exposed because quadriceps femoris muscle contraction has to be visualized. And this I think representation would give you a better way of evaluating that the thigh of the patient should always be exposed whenever you are going to be doing a knee jerk in a patient, so that you can elicit. No, you see the वो वही वाली बात है, टेक्निक की बात है. ऐसा नहीं कि, I mean, there are some gross errors here. It is just that in a quick consultation, doctor might be doing like this, trying to elicit the knee jerk of a patient. But ideally, I mean, the procedure would be that you are gonna be supporting the weight of one leg on your other hand. The weight of that leg should be supported, and the thigh of the patient should be yeah, Aditya, that's not an issue, but then the thigh should be exposed, no? And in the previous image, the thigh was not exposed. So the correct answer for 16th is option number beta. I've incorporated 2 questions on reflexes. This was a repeat one, so I think more people got this one right. Yes, Rudrash, now you said the right thing. Hanging will not be an exact word, but I can say that, yeah, the weight of that limb should be resting on your hand. Max weight of the leg should be resting on your hand so that the muscles are relaxed. I mean, I don't want the muscles to be under stress. So that would be a refinement of what we were trying to discuss. So we started with intermediary question on reflexes. I put up 2 of them. And let's move on to the next one. This one was on beaver sign. As you can notice, it's a cephalad movement, and it's not a caudal movement of the umbilicus when the person's neck is being flexed. Okay. Let's look at the next one. You are bound to get these kind of questions where there would be a big report present with a couple of images. Yes, Dr. Khan, you are right in the point. Okay, coming to the 10th one, he says, which of the following is not a component of the prognostic score for liver transplantation in a patient whose naked eye examination LFT report is shown? So very classical image, that brownish green ring can be seen. So I can pick up a KF ring in this particular case. Plus I can notice that the person is having derangement of his liver enzymes. The more important thing is total bilirubin, direct and indirect, all are elevated. The moment I check out this reflex where SGPT is elevated, SGOT is elevated, and all types of bilirubin are elevated, conjugated as well as the unconjugated variety, it tells me that I'm dealing with a case of hepatocellular jaundice. Now, what condition would be talked about in this particular question is Wilson disease. And the moment I know that I'm dealing with a question on Wilson disease, how I'm picking up Wilson disease is on basis of two findings which are given to me: KF ring, that is the brownish green ring present circumferentially, and at the same time presence of hepatocellular jaundice, bilirubin is elevated, both the direct component and the indirect. If only direct was elevated, I could have thought in terms of cholestasis also. If only direct was elevated, I would have thought in terms of cholestasis. Both are elevated, I would think in terms of hepatocellular jaundice plus SGOT, SGPT are elevated in this person. And at the same time, the question says which of the following is not going to be considered in the prognostic score. So in Wilson disease, the prognostic score that we use is called as Nazar's index. Nazar's index is used to decide the need for liver transplantation, and it will incorporate three parameters. It will incorporate serum bilirubin, it will incorporate aspartate, that is SGOT, will incorporate prothrombin time, but will not be incorporating serum ceruloplasmin. Serum ceruloplasmin is a test for diagnosis of Wilson disease. It is not a test to decide the need for transplantation in Wilson disease. I repeat that again. Serum ceruloplasmin is a test that helps in diagnosis of Wilson disease, especially in a case of positive family history. But serum ceruloplasmin does not decide the need for a liver transplantation in a patient. So the correct answer for this one would be, because we have selected A, B, C, the correct answer for this one would be option number C. Okay, I got option number A coming up. Okay, maybe I should have labeled it as 1, 2, 3, 4. So option number 3. If I label this as 1, 2, 3, 4, then option number 3 is the correct one for the correct answer. So thanks, Vicky. If you are enjoying the session, great. Wilson is a hot favorite of FMG people. National board, they'll ask Wilson disease, sir. Okay, so we sorted with question number 10. Option number 3 is the correct one for this one. The basic hack, guys, in case you missed it, I'll repeat that again. Ceruloplasmin is useful for diagnosis of Wilson. But ceruloplasmin is not a test that is going to decide the need for liver transplantation. Read the question. Not a component of prognostic score for liver transplantation in the patient shown. The question did not say how do you diagnose the condition. He says this need for liver transplantation. So go towards the end of Wilson disease. That's where you will read about Nazar's index. Yeah. What is not a component? No. Yeah, that is what I'm saying. No? Ceruloplasmin is not a component. A, B, C are a component. D is not a component. Yeah, which is not a component, no? Okay, fine. Wording is fine. I agree to the point that wording issue is there, which is not a component. Absolutely. So not a component would be only D, and there is no option like option number D there. Okay, so I agree. Bonus mark for you guys. Yes, Akshay, I get your point. It is the basic concept. The basic gist of the question is that ceruloplasmin is not a component. Let's solve it. Only D will be the only option number D तो है ही नहीं ना यार, तो मैं इसलिए कर नहीं सकता सर. The criteria are called as Nazar's index. Okay. Sorted with this one. Let's move on to the next one. MELD तो खैर पढ़ा ही हुआ आपने. And then we have MELD NA also. So in MELD NA we'll have bilirubin, INR, creatinine, and then we also take into consideration serum sodium also. And need for dialysis. And these are a couple of criteria which are used for deciding the need for orthoptic liver transplantation in routine cases. In case the question is going to be dealing with, let me say, hepatitis C induced end stage liver disease, and he says how would you decide the need for liver transplantation, then MELD or MELD transplantation or MELD score would be useful. Okay guys, so we move on to the 11th one. 35-year-old shepherd presents with the painless enlarged liver, and the CT abdomen of the patient is shown. Dr. Salim, thanks for the compliments. Thanks to the lighting. You look better in bright lights. Okay, 35-year-old shepherd presents with the painless enlarged liver. The CT abdomen shows presence of which of the following? And you can notice multiple septations present here. So the person is having a cartwheel pattern. That would be for hydrated cyst. The correct answer for this one is option number C. Pretty easy to pick up. In case it was a solitary cyst, then they can give you an image like this. You once again can see, the weight is shown, the cartwheel pattern for hydrated. Whereas if it's a solitary cyst like this, then you have to think in terms of amoebic liver abscess. In amoebic liver abscess, it's always a medical management. In hydrated cyst, obviously, because if I try to do a percutaneous aspiration, there can be risks of anaphylaxis as well spill over into the biliary tree. So we'll prefer to do either a pair or going for surgery directly. In fact, the best way for handling a hydrated would be, especially if the cysts are very large and they can rupture, then we'll obviously give medical therapy, but then surgery and pair are two options that we have at our disposal. For amoebic liver abscess, if the size of the abscess is more than 5 centimeter, only then we go in for aspiration. Otherwise, there is no need for an aspiration. This criteria is only valid for abscess on the right side only. For the left side, irrespective, for amoebic liver abscess, irrespective of the size on the left hand side, because it can rupture into peritoneal cavity, it can rupture into pericardial cavity, we will have to take into consideration. Dr. Rakesh, considering that if you have a patient with a shorter history with fever and high grade fever, chills, rigors, and you are having a hypoechoic lesion visible, you will first think in terms of possibilities of amoebic liver abscess. Okay, so we are sorted for 11th. Good inputs from you guys. Let's move on to the next one. This question is about a kid. He's presented to me with a petechiae and a bruise on the forehead. Initially, I thought he got injured while playing. You can notice substantial petechiae on the forehead, a big bruise on the forehead of the kid. Sternal tenderness for an abscess, sir, we'll do an ultrasound initially, and then I mean, most of the time ultrasound would be more than sufficient for identifying that. Okay, sternal tenderness is absent, so we are ruling out leukemia. I mean, if it is acute lymphoblastic leukemia, we usually get sternal tenderness. Liver and spleen are not palpable. Organomegaly is always a feature with leukemia, so this is off the discussion. When it comes to dengue hemorrhagic fever, we need to take that into considerations, considering India would be an endemic zone for it. Yeah, because in the question is mentioned about bone marrow aspiration. That means it's unlikely to be dengue because the doctor would have ruled out the possibilities for the same. I'm left between aplastic anemia and acute ITP. The correct answer is acute ITP. We do not get an organomegaly in a patient, and more importantly, there would be low platelet count in a person. Why not aplastic anemia? You should be having a pancytopenia. There is no mention of any pancytopenia given in this question. So acute ITP is the first answer here. What would you use for treatment, guys? Yep, doctor, the answer for this one is option number B only. Acute ITP. Aplastic anemia should be having pancytopenia. Leukemia should have organomegaly. Leukemia should be having sternal tenderness. That's why C is out. And dengue hemorrhagic fever, yep, I'll consider that. But there's no description classical given for like the fever went down. Like in dengue, hota kya ki when fever goes down, that is when the thrombocytopenia or the dengue hemorrhagic fever manifestations develop. So that classical dengue profile is not given. Okay, no sir, it will not be dry tap on aspiration. Yep. Splenectomy is for chronic. That's the bruise. There's a big purpura. The kid is having a purpura. Purpura matlab palpable bleed in the skin. In a person having low platelet count, you get petechiae. Petechiae look like mosquito bites, but they're non-blanching in character. And then the bleed can be so big that it can be in the form of a purpura as well. Not plasmapheresis, guys. First for acute ITP. डॉक्टर साहब पहले तो मेन वीडियोस कर लो, अभी तो टाइम है, फिर उसके बाद में कर लेना रैपिड रिवीजन, 5-6 दिन की बात है. Yeah, doctor, he could have got injured and then converted into a bruise subsequently. Sir, I asked treatment for acute ITP. I'm getting varied answers. I'm getting steroids as an answer. Steroids are used, okay, but initially platelet count is very low. Then what will you give? You will give immunoglobulins, man. You can be using immunoglobulins in a person, especially with the platelet count being low to the level that he's having substantial amount of bleeding. We can give IVIG in the patient, and subsequently it is obviously, I mean, we can use steroids or we can plan splenectomy. That is for the chronic variety of ITP, but in acute ITP we can be using IVIG, and obviously the first answer would be immunoglobulins. Very good, very good. So I had correct inputs for question number 12. Platelets thoda neglected रहता है. Coming to the next one, we have a 12-year-old kid presents with fever, sore throat for 3 days, and posterior cervical lymphadenopathy. There's a neck mass present, cervical lymph nodes present, fever for 3 days, and peripheral smear of the kid is shown. Yep, right. On, I mean, steroids subsequently. Yes. So this what is present is a lymphocyte. I mean, normally a lymphocyte will have a very well-defined nucleus, but in this case, the lymphocyte nucleus is appearing a bit distorted. So this would be an atypical lymphocyte. The clinical diagnosis of this patient is infectious mononucleosis. The key in this question is this peripheral smear finding of atypical lymphocytosis. Yeah, visible now. Atypical lymphocytosis, a fragile lymphocyte present here. So pretty straightforward. Short history. In 3 days history, I will not consider lymphoma. In CLL is anyway found in adults. And option number A is gonna be not found on 3 days history. Herpangina will present again with vesicular lesions. It would be with Coxsackie, and this would be causing vesicular lesions, that hand, foot, mouth. So this would be rather atypical lymphocytes, which we are taking into consideration. Absolutely. Answer to 13 is C. We move to the next one. Given MRI head, you can see a focal lesion present. And let's look at the input from you guys. Craniopharyngioma. Which one? This one, infectious one. No, this was straightforward. No? Kissing disease, no? 12 साल का बच्चा है ना, तो मतलब क्लोज पर्सनल कांटेक्ट से उसको एब्स्टिन बार वायरस आ गया होगा, उससे इन्फेक्शियस मोनोन्यूक्लियोसिस हो गया. ओके, क्रानियोफैरिंजियोमा, आई एम गेटिंग डी एज एन आंसर. मेडुलोब्लास्टोमा, तो मेडुलोब्लास्टोमा कहाँ से ओरिजिनेट करेगा यार? मेडुलोब्लास्टोमा तो ओरिजिनेट सेरिबेलम से करता है. Option number D should originate from medulloblastoma, is gonna be originating from the cerebellum of the patient. So option number C and D cannot be the answer to this question, because cerebellar astrocytoma तो cerebellum से originate करेगा और medulloblastoma भी cerebellum से originate करेगा. तो बच गए दो, craniopharyngioma and a pontine glioma. तो craniopharyngioma कहाँ होता है गाइस? craniopharyngioma तो यहाँ पिट्यूटरी वाले एरिया में होगा ना. Craniopharyngioma का जो लोकेशन होगा, this is where the pituitary is gonna be located. No, this you can see is the corpus callosum of the patient. Sir, not every image that would be given to you will be that of a craniopharyngioma. आप location तो देखोगे ना sir. You can notice the corpus callosum, then you can notice the third ventricle of the patient, and इसके नीचे यहाँ पे thalamus है, thalamus के नीचे hypothalamus है, और उसके बाद में pituitary होगा. In fact, maybe the green marking is not visible, so I'll use a different color here. Okay, this is what I'm saying, guys. This would be the area of the thalamus, then is gonna be the hypothalamus, and then is gonna be the pituitary in the patient. So craniopharyngioma is gonna be located at an anatomically different side. You can see a huge expansile tumor causing lot of vasogenic cerebral edema. In fact, मुझे पूछना चाहिए था कौन से टाइप का cerebral edema होगा यहाँ पे, तो it would be a vasogenic. The type of cerebral edema which is present here is vasogenic cerebral edema. So there's a lesion present here in the pons of the patient. The correct answer for this one is option number B, that is a pontine glioma. Yes, guys, I mean, every time they give you an MRI, they're not always gonna give you a craniopharyngioma. So I know that, you know, that's the usual thought process, but then the location has to be taken into consideration as well. And why it is not D? Because medulloblastoma would again be originating from the cerebellum of the patient. So C and D option related to cerebellum. Option number A, much more superiorly located. This brain tumor has sir 100% mortality in 6 months. Pontine glioma, if it's commonly seen in children. Pontine glioma in a kid can have 100% mortality in 6 months. One of the highly aggressive tumors. And calcification seen in craniopharyngioma. Agreed, that's the point that is to be remembered. But the location of the tumor was not related to the cellular mass. I mean, craniopharyngioma is a supracellular mass. It's located close to the pituitary. Okay, we sorted for 14 and we move on to the 15th one. We have a teenage boy who is found to have a symmetrical biceps, triceps, and a calf muscle weakness as shown in the schematic. Elder brother of this particular case, हाँ जी, दिया हुआ. Bhaskar, sure, I'll do that. Bhaskar, I'll do that. Date आपने करी दिया 3rd June. I'll do that. Sure. No worries, Bhaskar. I'll do that. Teenage boy is having a symmetrical biceps, triceps, and a calf muscle weakness. Schematic में दिखाया हुआ है. And elder brother died of heart disease at 30 years of age. Which of the following diseases should be considered? तो यहाँ पे आप देख ही रहे हो कि deltoid का weakness है, biceps, triceps का weakness है, calf muscles का weakness है. And I'm getting great answers. Okay, okay, fine. Okay, for those who are commenting A, तो मुझे ये बताओ कि in Duchene's muscular dystrophy, is the presentation of calf muscle weakness or is it calf muscle hypertrophy? In Duchene's muscular dystrophy, I mean, I understand because elder brother died at 30 years, so possibility elder brother could be having Becker's muscular dystrophy, right? That's your thought process. Agreed. But do you get a calf muscle weakness in Duchene's muscular dystrophy? No, you get hip joint and hip girdle muscle weakness. जो Duchene's muscular dystrophy का weakness होता है, I'll show you the pattern. I'll show you the pattern. Yes, it's a pseudo hypertrophy. Duchene's का pattern सर ये वाला होगा. Duchene's में जो weakness होता है, वो weakness होता है around the muscles of the hip joint. So person has a Gower sign. There is weakness of the deltoid, there is weakness of the shoulder, there is weakness of the neck muscles. So if they give you a schematic like this is Duchene's muscular dystrophy, and in these patients you would be having a calf muscle hypertrophy. In this particular question, if you read it carefully, there was no mention of any calf muscle hypertrophy, which is why the answer to this question is not option number A. The answer to this question is not option number A, guys, because you need to have a calf muscle hypertrophy and the pattern of muscle involvement is not. यहाँ पे calf muscles की जो कौन यहाँ पे calf muscles involved है, shoulder muscles involved है. This is not option number A. अब आते हैं C पे, limb girdle muscular dystrophy, which was another answer that I got. In limb girdle muscular dystrophy, again the weakness is around the muscles of the hip joint here, so there is no muscles involvement around the hip joint. I'm ruling out option number C and A because in both of them, let me just write it down before you. Why have I ruled out option number A and option number C? Because both of them will be having weakness of muscles around the hip joint. It is the hip girdle joint muscles where the weakness is present. That is why you get a very classical Gower sign in these patients. I'll show you the Gower sign also in a second. But in this question, there is no mention of any Gower sign present. So we are left between now two options, B versus D. For D option, congenital myopathy will not present in teenage age group. Congenital myopathy will cause death in usually first year of life only because the muscle weaknesses will be so bad that you could be having diaphragmatic weakness and the patient will die before they attain their first birthday. The point case, yes, this was a tricky one, guys. Option number D is ruled out, congenital myopathy, because congenital myopathy will be fatal in the very first year of life. The weakness is going to be very severe. Diaphragmatic muscle weakness will cause recurrent pneumonias and die. The answer to this question is option number B, that is Emery-Dreyfus. What you had to do was solve this question on exclusion. The first and the foremost thing that you have to pick up in this question was कि क्या इसमें calf muscle hypertrophy, pseudo hypertrophy लिखा है, calf muscle weakness लिखा है. It is not a hypertrophy written, it is a calf muscle weakness. This pattern that I've shown here before you is that for Emery-Dreyfus, it's a question which is little difficult because we're talking about INI-CET. So INI-CET is something where obviously, you know, the routine things, they'll give you some repeat questions, but some will obviously be new ones. So I had to put up a couple of them. I mean, you know, I've discussed those PYQs with you also, but then at the same time, you will get a mixed bag response in the actual exam where a lot of questions that would be asked would be relatively new and would be having a bit of twisting. Rakesh put up that point, will it be Becker's? That is the first thing Rakesh has said, because elder brother died at 30 years of age. I thought elder brother is having Becker's and the younger brother is having Duchene's, but then Duchene's should be having weakness of the muscles around the hip joint. Look at this area, there's no involvement. I hope you can see my green marker. There is absolutely no weakness at the area which I've just highlighted because there's no Gower sign documented, because there is no calf muscle hypertrophy word written. I cannot think in terms of Becker's also. I repeat the point once again. Becker's will have weakness यहाँ पर and will have a hypertrophy. यहाँ पे weakness लिखा था. So the answer to this question is Emery-Dreyfus. A couple of patterns which we can just quickly revise here. The first one that I've shown before you is Duchene's muscular dystrophy. In fact, Duchene's muscular dystrophy and yes, Becker's is milder Duchene's, exactly. 1 and 5 में difference यही है कि यहाँ पर neck muscles का involvement नहीं है. Neck muscles are not involved. So this is LGMD, limb girdle muscular dystrophy. This image that I'm showing you guys, if you go through neuro में ना last में there is a video on Duchene's muscular dystrophy, उसके last में mentioned है. and I think RR में भी है, but even in the main video, no, even in the English version, you check it out. This diagrammatic representation is there for Duchenese versus LGMD. I mean, though obviously for Duchenese, I need a calf muscle hypertrophy to be given in a question, dystrophin to be described. But then the way the description is, neck muscles are involved in Duchenese, neck muscles are not involved in limb girdle muscular dystrophy. और अगर congenital myopathy होगा, then whole body weakness होगा. If it's a congenital muscular dystrophy, then the chances of person surviving will also be very substantially less. The second image that I've shown is for, in fact, the fifth image is for facioscapulohumeral dystrophy, FSH. So slightly a difficult one. I'll rate it like this as compared to what normally should be. The answer is not going to be option number 8, calf muscle. The key word of the question, मतलब minimum message मैं बोल रहा हूँ अगले 15 seconds में, before we move on to the next one, is calf muscle hypertrophy नहीं है इसमें, calf muscle weakness लिखा है. Duchenese में weakness hip girdle पे होगा. Okay, we sorted for 15th, so let's move on to the 16th one. Okay, this was the classical Gawar sign. Dystrophin gene is one of the largest genes. Deletion is what happens. I mean, they can just ask genetics also, no? So what is the commonest genetic mutation found in dystrophin gene? Then it would be a deletion in 65% cases. Plus they have given images in which you will notice stork leg appearance. There might be contractures in the leg also. So if you get stork leg appearance, you have to think in terms of Charcot-Marie-Tooth disease, CMT. That is going to be hereditary sensory motor neuropathy. And then for Duchenese, obviously this calf muscle hypertrophy would be present. The child will stand in a very peculiar position, that is lumbar lordosis. Lumbar lordosis, toe walking, and hypertrophy of the calf muscles is a feature that you see with respect to DMD, that is Duchenese muscular dystrophy. Okay, guys. Moving to the next one. 16th is sorted out. We talked about the knee jerk already. Let's move to 17th. 45-year-old minor from Jharkhand presents with complaints of waking up daily with early morning headaches and vomiting episodes. So he is talking about a minor, and the minor is having CNS symptoms. Dr. Stephen, on the right hand side of that, no, there's a mnemonic that I've discussed for the SAG values for the exudative variety. So my suggestion to you would be, first try to write down from a mnemonic that is given in the SAG chapter for the right hand side, where the SAG values are for inflammatory conditions, and then try to focus on the one on the left. You will be able to do it, I'm very sure. Okay, guys. We have a minor with CNS manifestations. He's having early morning headaches, vomiting episodes, dilated neck veins, and chest X-ray and CT scan is shown. So let's look at what you guys are thinking here. He's a minor. There are metastases to the brain probably, because I can see a couple of white spots here which look like Mets, and there is a central lung mass in a patient. So can I have the answer, please? Okay, I'm having answer as non-small cell cancer. I'm getting A as an answer. Sir, they're already updated, sir. Dr. Kavi, I think you'll notice a lot of them in the black background. They're all updated ones. Okay, guys, I am getting various feedbacks here. Pleural intracranial calcification. Okay. Guys, I think one, you can notice a central lung mass here. The moment I say central lung mass, what will you think of? Will you think of terms of a small cell cancer or a non-small cell cancer? I know most people are either saying A or they're saying B. That's the usual chat that is going on. When you say central lung cancer, will you think in terms of a small cell cancer or non-small cell cancer? Because I think I have said that alphabet multiple times, no, S and C, that small cell cancer is going to be central in location. It is squamous and small cell, which is going to be central in location, and one that usually spreads to the brain is small cell cancer. The correct answer for this question is option number A. This person is having, because what you have to correlate is that there is a lung mass. Forget about central lung mass. At the moment, first thing is there is a lung mass visible, because there is an arrow which is given in this X-ray, and you can notice if I zoom in, this is a circumscribed shadow of a lung mass which is described. The moment you know a lung mass, whenever you see a lung mass, it can spread anywhere and it is going to the brain. That is why CNS manifestations are present. So your next thought process will be, which cancer goes to the brain? Small cell cancer, because it exhibits micrometastasis. This is a small cell cancer, guys. It's because of the micromets that we are having these I mean, the micromets have become pretty big at the moment, but that they are contributing to CNS manifestations in the patient. Point number B, non-small cell cancer, adenocarcinoma and large cell cancer are unlikely to exhibit micrometastasis right from day one. And another hint for why this is more probably a small cell cancer is because he's talking about a miner from Jharkhand. तो झारखंड में जो माइंस हैं वहाँ पे तो इनफैक्ट मतलब कोल तो होता ही होता है, कोल के साथ में हमारे यूरेनियम के माइंस भी तो वहीं पे लोकेटेड है ना सर. जो न्यूक्लियर प्रोग्राम है गवर्नमेंट का, where they are planning to set up these nuclear reactors, multiple nuclear reactors, because the only way for going ahead in India if you want to avoid pollution is not coal fire, coal based power plants. It's basically nuclear power, right? So India is going expansive on especially uranium mining. We're buying it from foreign countries as well. But then we have uranium mines in Jharkhand which can explain the linkage here. But even if you आपको वो component नहीं पता कि यूरेनियम की माइनिंग कहाँ से होती है, कोई फर्क नहीं पड़ता, right? That is just additional fact that I can say. Sir, we'll consider that in an X-ray to be close to the hilum. We'll say this is a hilar mass. On an X-ray, if you look at it from a radiologist perspective, we'll call it a hilar mass. We'll not say it's peripherally located. Peripherally होता तो फिर यहाँ पे दिखाता मैं आप. We'll call it a hilar mass, right? So it's I mean it's not important to know where is uranium mined from, but yep, it's important to know that which cancer has a higher probability of going to the brain. That would be a small cell cancer. Exactly, Urmi. That's the next point I was coming to. Why are you having why are you having dilated neck vein? Central lung mass. Central lung mass is pressing on the superior vena cava. In fact, you have made my job easier, guys. You know, the query was coming was, sir, is it not looking peripheral? If it was peripheral mass, it will not press on the superior vena cava. Now I hope it is clear, guys, that central lung mass will press on the SVC, and because of the pressure on the SVC of the patient, there would be a development of prominent neck veins in a patient. So this satisfies even our next point. So if you look at it in totality, we are having an individual, forget about minor. In totality, what your understanding is, guy is having a CNS event. तो मुझे brain में कुछ lesions दिख रहे हैं, तो मुझे लगा यार parasite की lesion हो सकता है इंडिया में तो. But because lung mass was given, so I'm thinking, okay, it's unlikely to be parasitic. It must be some kind of a tumor that has gone. Which tumor usually goes to brain? Small cell cancer. How do I know it is small cell? One is that location, the central part. And second, another hint. Superior vena cava constriction, superior vena cava compression, superior vena cava syndrome can contribute to dilated neck veins in a person. So the correct answer for this one is option number A. Great job, guys. Let's move on to the next one. This is relatively easier. A 45-year-old patient with ulcerative colitis presents with multiple painful lesions on both legs. You can notice these ulcers close to the medial malleolus on the shin of the patient. And the chap is having ulcerative colitis. I mean, if I was giving you image like this, you could have thought in terms of a person having a venous ulcer, but considering ulcerative colitis is given, it's a spot on answer. You look at it and you know the answer. That would be pyoderma gangrenosum, which is a dermatological manifestation seen with patients of ulcerative colitis. So that's how it's gonna be, guys. You're gonna get one slightly tricky one, one easy one. Roller coaster ride है, उसको राइड करना है 3 घंटे कंटिन्यूसली. जितना अग्रेशन फर्स्ट मिनट ऑफ एग्जाम, उतना अग्रेशन नेक्स्ट मिनट लास्ट मिनट ऑफ द एग्जाम. Okay, let's move on to the next one, guys. Barium swallow of a patient is shown. And the question says, what is the appearance that is shown here? Let's wait for your inputs here quickly. Absolutely. Okay. Okay, जी, apple core appearance तो दो, maybe the surgeons love to talk about it, but apple core is what we read with colon cancer or carcinoma colon, so I'm ruling that out. Bird beak, I can see in fact 2 beaks present there, so it's very unlikely to be that classical bird beak appearance. I'm left between Schatzki's ring and an esophageal web. We can notice this indentation in the lower part. This person, if we look at the history, the problem will most of the time be difficulty in eating non-vegetarian food. वो बोलेगा चिकन बट मटन बिरयानी खाने में दिक्कत होता है, राइट? बट व्हेन आई ईट वेजिटेबल्स और यू नो व्हेन द फूड इज वेरी वेल कुक्ड, देन आई डोंट हैव अ प्रॉब्लम. दैट्स वेरी क्लासिकल प्रेजेंटेशन फॉर Schatzki's ring. The correct answer for this one is option number B, Schatzki's ring. Why it's not a D? Because esophageal webs would be present in the upper part, no? I mean, most of the time, esophageal webs are gonna be located in the upper part of the esophagus. And here you can notice the tapering part coming up. So we are reaching the lower esophageal sphincter. So because the indentation is present at the lower part, the filling defect is present in the lower part. So I'm thinking in terms of a Schatzki's ring in the patient. Answer to this one, 19th is Bombay. Let's move on to the next one. Okay. Only point is the food will be relatively, I mean, well cooked. So, I mean, semi-solid food can go down easily as compared to food contents which are relatively, I would say, more difficult to digest. Okay. 65-year-old lady presents with soft swelling on her left supraorbital area, which she says is warm to touch. She has been taking herbal medicines for these swellings for last 6 months. And you can notice that she's having a swelling in a thyroid gland, and this swelling in the thyroid gland has probably metastasized to her skull also, and because of which you can notice that there is a osteolytic, there is complete destruction of the skull. So all you need to do is pick up the fact that she's having a thyroid tumor. That's the first thing that you have to pick up in this question. This thyroid tumor has metastasized to the skull. Which thyroid tumor? Though the answer is very much written now, sir, it's not a Pott's Puffy tumor, because Pott's Puffy tumor will contribute only to a swelling, but it's an osteomyelitis. It will not cause a osteolytic lesion. What I am teaching you today is extreme pulsatile metastasis. Sir, you would have read about the most common thyroid tumor being papillary cancer, which shows a lymphatic spread. But one that has a hematogenous spread is follicular cancer of thyroid. This can result in, this has a hematogenous spread. This hematogenous spread can result in development of pulsatile metastasis. In fact, these are again questions which can be asked to you straight away. Which condition produces a pulsatile metastasis? It's going to be follicular cancer of thyroid. Why is it pulsatile? Because now what internal carotid artery pulsations can be transmitted to this soft tissue swelling, because the skull bone is eroded by the cancer that is metastasized in this case. The correct answer for this question is option number C. I agree to the fact that this question is interdomain. You would have thought in terms of Pott's Puffy tumor. Pott's Puffy tumor is going to be a frontal bone osteomyelitis. The person might be having presence of fever. Person might be having a soft tissue swelling. And that soft tissue swelling will not resolve with obviously herbal medicines. But look at the history, 6 months. 6 महीना से तो पॉट्स पफी ट्यूमर नहीं हो सकता ना सर, फ्रंटल बोन ऑस्टियोमाइलिटिस हो रहा है. सो ओके, सो द पॉइंट इज गाइस, 6 महीना से तो you are not gonna have a osteomyelitis persistent in a patient and the person is living. I mean 6 महीना तो कोई osteomyelitis बिना एंटीबायोटिक्स के तो यार osteomyelitis तो it will cause extreme amount of damage, right? Or it will cause problems. So yeah, doctor, the point is I have to induce that spirit of fighting in you, fighting in a positive sense, that the questions have to be slightly tricky ones and you have to think one step ahead. So answer to 20 is gonna be option number C. Osteoid osteoma will be a painless swelling. Mainly the pain will be more at night, and again osteoid osteoma will not cause a osteolytic lesion. I mean here what you can see is the osteolytic lesion. और ये pulsatile क्यों होता है? क्योंकि मैंने रीजन बोला सर, ब्रेन का जो कैरोटिड आर्टरी का पल्सेशन है ना, that would be transmitted to the soft tissue swelling that the person is happening. I mean the bone is eroded. I mean that is the kind of, you know, the damage that follicular cancer can contribute and can cause problems in a patient. The correct answer for 20 is option number C. Okay, great guys. Yeah, doctor, that is fine. I mean herbal medicines can contribute to, because we don't know the exact constitution, so thyroid function can be deranged. Okay ji. This question I put up just for the sake of completion. I wanted to show that, you know, that cartwheel appearance. The answer is anyway hydrated cyst. We have talked about an image like this earlier also. It is just for the completion part that I wanted to incorporate this. The answer to this one is option number B. And how do you differentiate between an amoebic liver abscess versus a pyogenic liver abscess? Amoebic liver abscess will usually be solitary, and pyogenic liver abscess जो होगा वो multiple होते हैं. And pyogenic liver abscess में person will be septic. Here you notice, if you read the history, the person is having a dragging pain in the right hypochondrium. but as such there is no fever which is described. There is no high grade fever with chills and rigors. Why this is not a pyogenic liver abscesses? Because septic features in this patient or in this question are not given. Otherwise it could be septic, it could be a pyogenic liver abscess as well. It's mainly because, yeah, shepherd is another history. I mean, shepherd is another history because contact with animals ho gaya. So that would be another hint present. But even if shepherd word was not given, I mean, how do you differentiate? Pyogenic would be septic focus present in the body. So high grade fever with chills and rigors would be present, which is not given in this case. Okay, guys. Moving to the 22nd one, we have this 15-year-old patient presents with eczematous lesions for last 5 years. 5 साल से. The lesions have progressed as plaques, multiple red lesions found on the trunk of the patient. The bad news now is that the person is having an organomegaly and an increased TLC. The moment I read about increased TLC and organomegaly, I'm thinking in terms of a malignancy. See, there's a history of 5 years. There is an organomegaly in a patient. There is an increased TLC. So I'm thinking in terms of possibility of malignancy in a patient. What you can pick up here is very peculiar cells which are called as, yes, can I have the, yes, what would be these cells called as? I mean, these are T cells and they are very peculiar in shape. Yes, these would be Sézary cells, exactly. This particular patient was initially having mycosis fungoides. Mycosis fungoides can present with eczematous lesions. The presentation of mycosis fungoides is erythroderma, which is the reason why in this question initially the disease began as though 5 years is a history which is very long. I mean, normally a tumor will not take such a long time, but sometimes, you know, maybe there could be some issues with the description in a question. I'll take it at the face value. Mycosis fungoides presents with erythroderma, and then subsequently the tumor is going to spread from the skin to the liver and the spleen and is going to cause an increase in the TLC of a patient. So we are having a tumor spreading from the skin, which is why we are calling it a peripheral or a cutaneous T-cell lymphoma. The answer to this question is option number A. The question is based on 2 facts. One is the peripheral smear finding, which I think everybody picked up very beautifully, the cerebelliform appearance, great. And the second would be the concomitant presence of reddish lesions on the skin of a patient. So that's where the tumor originated from, the skin, and then moved on to the liver and the spleen. So this is Sézary syndrome. Sézary syndrome would be a disseminated form of mycosis fungoides. Mycosis fungoides would mean the disease is localized. And once it begins to spread, that's when we call it cutaneous, the cutaneous T-cell lymphoma spreads, and that's when we call it a Sézary syndrome. So the answer to this question would be option number A. Diffuse large B-cell lymphoma is the commonest non-Hodgkin's lymphoma, and most of the time this will present as abdominal lymphadenopathy. I mean, when you look at option number C, DLBCL, it will mainly present with features of subacute interstitial obstruction. Just like Hodgkin's lymphoma will present with rubbery lymph nodes in the neck, non-Hodgkin's lymphoma will mostly present as massive enlarged lymph nodes in the abdomen, contributing to subacute interstitial obstruction, or can contribute to even, you know, retroperitoneal compression and ureteric compression, and can cause hydronephrosis developing in a patient, or porta patis lymph nodes can enlarge and they can cause obstructive jaundice in a patient. And HIV positive patients, in HIV the subtype which is present is immunoblastic lymphoma. In fact, for HIV positive, you will notice there's a variant of diffuse large B-cell lymphoma that would be immunoblastic lymphoma, that's seen with HIV positive patients. Lymphoplasmacytic lymphoma is seen with hepatitis C. Those are associations that you read in pathology. But then for BCD, the main presentation is going to be abdominal lymphadenopathy. Yep. Moving to 23, there's a bone marrow specimen which has been reported as hypocellular by the pathologist. And he's saying that percentage of, I mean, marrow cellularity should be less than how much to call it. I mean, when you count the cells, no, marrow cellularity should be less than how much to call it hypocellular. I mean, you read this term so many times, no, hypercellular and hypocellular marrow. So hypocellular definition cutoff has been asked. Though you can notice, I mean, the bone marrow specimen, bone trabeculations can be seen, and then most of the time it's mainly fat present. I'm getting answer as a C. I'm getting a lot of fat cells, yes. Yes, guys, I'm waiting for your answers. No, guys, it's not 20%. It is not 20%. It is not 10%. 20% is for blood cancer. that is leukemia cutoff. 10% is for multiple myeloma. For hypocellular, the marrow cellularity should be less than 25%. You can take a snapshot of it because this is the part that is usually neglected. Whenever we have severe aplastic anemia, the definition is marrow cellularity less than 25%, along with these findings of neutrophil count being less. At least 2 out of 3 should be present. Neutrophil count should be less. I'll just use a different color. Neutrophil count should be less, platelet count should be less, or retic count is lesser than the cutoffs which are present. Then we have very severe aplastic anemia as well. And because this is usually not very well focused, so I thought I'll just incorporate a question on that, because somebody actually sent me a message saying, sir, what do you mean by the word hypocellular marrow? You said that word so many times. So hypocellularity cutoff is what I've tried to incorporate in this question. The definition is a bone marrow cellularity of less than 25%. That's there are different cutoffs. One is for residual hematopoietic cells, but the standard definition is what I've tried to incorporate here. Sir, we'll go for bone marrow transplantation ASAP in a person as soon as possible. We'll go in for a allogenic bone marrow hematopoietic stem cell transplantation would be the best way for management. In case we do not have available bone marrow transplantation, then it is palliative care which we do routinely. We give transfusions to these patients. That's the only way for survival, but then the best way would be a hematopoietic stem cell transplantation. Answer to 23 is delta. The reference is given here, guys. You can take a snapshot from it. Even if you check in Ventro's hematology, you can ping the pathologist as well for this. The standard answers would be what I've just highlighted. Okay, so we have another one. Yep, difficult one. Yep, coming to 24. Patient complaints of missed beats. I have helped you by putting up the vertical arrows for the missed beats as well. And the question says, which is the rhythm that is shown here? Yes, guys. Okay. Okay, Mobitz one heart block. Mobitz one heart block will be having a prolongation of PR interval. No, let me just use a marker here. This is the missed beat. So what we're gonna do is check out the PR interval before the missed beat and after the missed beat. And you are noticing the fact that both of them are equal. At least on a gross level, it is not. Okay, let me use a different color. In the missed beat, the PR interval is looking almost to be the equal size. So one possibility is it is Mobitz 2 heart block. I've explained multiple times that whenever you're sitting for an INI-CET exam, the problem with INI-CET people is that they don't like to ask routine things. They love to ask you differential diagnosis of Mobitz 2 heart block. Now listen to my words very carefully. I'll just put a marker, green marker at the moment. So please look at the screen. This is normal sinus rhythm, PQRST. This is normal sinus rhythm that I'm currently showing in green. Let the green fade away. And then I'll put another green pointing. This is the P wave, which is not being conducted because the green pointer that I put is for the P wave. The green pointer is fading. After P wave, there is a missed beat. Let me do it again. Normal sinus rhythm. That means conducted P wave. And then what I'm putting is a P wave which is not conducted. P wave which is not conducted. So it's an alternate thing that is happening. One is, look at the green, conducted P wave. Why I'm saying conducted? Because after PQRS is coming. Now let it fade out. Let it fade out. Now focus on this P. This P is not conducted. Not conducted. Why? Because not conducted because there is a heart block present. So this is the differential diagnosis of a Mobitz 2 heart block. The correct answer for this one is 2:1 block. I wanted to read up the topic of heart blocks very well. In last time's INI-CET exam, it was Mobitz 2 heart block. You will notice the pattern. One time they have asked Mobitz 2, one time they have asked 2:1 block. पिछली बार Mobitz 2 पूछा था, इससे पहले 2:1 block पूछा था, alternate करके पूछ रहा probably. So I'm not predicting what will come in future, but my request to use only one, that every time you're gonna get a missed beat, check out the PR interval before and after. If it is unequal, it is Mobitz 1 heart block. तो वो तो पहले तो देखो थोड़ा सा आपको यहाँ मतलब small squares जो हैं वो maybe आप count नहीं कर पाओगे because the image due to the resolution issues will get a little faded away. So even what I am seeing at the moment, I'm not able to see the small squares in the relay. But grossly speaking, PR looks equal, and once I say it's equal, then it looks to be Mobitz 2, but then there is an alternative conduction happening, conduction, non-conduction. Let me highlight this once again. This is the conduction part, P के बाद QRS आया, T wave आया, then is a P wave non-conducted. Then is again a P wave which is not conducted, and it's followed by missed beat. So this is a differential diagnosis. So please just go through the heart block part once again so that you are able to get a hang of this data. Of alternatively, I mean, what is coming in the exam is movement 2 versus 2:1. Okay. हार्ट ब्लॉक सर आरआर में सर मैं 10 मिनट में एक्सप्लेन किया है, उसमें सुन लो सर. अब बाकी सारे लोग देर गोना बी asking about questions, so I would suggest you to listen to that in RR. It's hardly 15-minute things. The entire heart block is described in detail, sir. What is different for type 2? SRB, SRK लगा मुझे पहले. SRB, you need to rephrase your question. I'm just waiting for a second. What is different for how to differentiate? For type 2, Mobitz 2 heart blocks. यार Mobitz 2 में जो डिफेक्ट होता है बंडल ऑफ फेज में होता है ना. इन Mobitz 2 heart block the defect is in the bundle of phase, तो उसका कंडक्शन डिफेक्टिव होता है, तो इस वजह से ड्रॉप बीट्स आने शुरू हो जाते हैं. इन Mobitz 1 heart block the problem is in the AV node. AV node exhibits a slow conduction. तो एक को इंट्रा नोडल बोलते हैं, एक को इंफ्रा नोडल बोलते हैं. तो दोनों में फंडामेंटल फर्क ये है कि एक इंट्रा होता है, एक इंफ्रा होता है, तो इस वजह से दोनों में डिफरेंशिएशन आ जाती है. How will we differentiate between type 2 and this one? Diksha, one suggestion is RR में मैंने ये दोनों sequentially बताए हैं. Second hint is that in Mobitz 2, let me try it here. Mobitz 2, you're gonna be having like 5 beats a drop, 10 beats a drop, and when you check out the peer interval before and after, you will notice that it will be equal. I said 5, 10, 15. It may be any number. It can be 3, it can be 2, it could be 1, and उसमें number constant नहीं होगा. It's not gonna be like one conduction, one non-conduction. If it's one conducted and one non-conducted, then you call it 2:1. अगर वो ऐसे होता 4 चल गए, 4 normal sinus rhythm, then a drop, 3 normal sinus rhythm, a drop, 10 normal sinus rhythm, then a drop. If it is asymmetrically happening, then it is Mobitz 2 heart block. But if it is symmetrically happening, one conduction, non-conduction, one conduction, then a drop, then it is called as 2:1 block. So I hope I was able to explain this, and Shri helped me with that. Thank you, Shri, for the quick hack into this. Okay, let's look at question number 25, a repeat from INI-CET exam. You can see a filter here. Our objective is to generate leukodepleted blood. Our objective is to give to the patient less amount of leukocytes. So either the word used will be leukocytation, or leukodepleted blood would be alternative term that can be used for it. Our objective is, one is we can go in for irradiation of the unit of blood. That would be the preferred method. The preferred method of generating leukodepleted blood is irradiation. If not, then we can use a filter as well. And he says what can be prevented. Okay, I am getting a D as an option, so मैं इसको थोड़ा rephrase कर देता हूँ. Let me call this 1, 2, 3, 4. lymphocytes के अंदर cytomegalovirus जाएगा, so this transmission will be reduced. Febrile non-hemolytic transfusion reaction is again due to white blood cells only, so will be reduced. Sensitization of immune system is again by lymphocytes, it will be reduced. Bacterial sepsis, let's look at D, bacterial sepsis. Sir, bacterial sepsis is based on quality of blood bank, no? I mean, a filter cannot prevent bacteria from going in the body of a person. That's a separate issue, that if the bacteria is inside the lymphocyte, then it's a separate issue. But otherwise, if the quality control is bad, bacterial sepsis can occur because maybe the end part of the tubing or the IV cannula site was contaminated. It may not come from blood directly, but the tubing was getting contaminated, or the cannula site got contaminated. So A, B, and C are the correct one. The correct answer for this one would be given as option number 2. The correct answer here is A, B, and C are correct. But D cannot be prevented, sir. I mean, you cannot prevent bacterial sepsis from occurring by using any kind of filter or by using leukodepleted blood. Bacterial sepsis is quality control issue. Anyway, tell me which is more common after blood transfusion: hepatitis B, hepatitis C, or bacterial sepsis? Which is more common after blood transfusion? Bacterial sepsis, hepatitis B for Bombay, hepatitis C for Calcutta. Quick answers here. Post blood transfusion infection हो रहा है patient में, which is commonly seen. Yes, guys. सर सबसे ज्यादा तो बैक्टीरियल इन्फेक्शन होता है ना, ब्लड ट्रांसफ्यूजन के बाद में सबसे ज्यादा जो होता है वो तो सेप्सिस हो सकता है ना. ब्लड ट्रांसफ्यूजन शुड बी ओवर विद इन 4 hours. इफ इट टेक्स अ लॉन्गर टाइम बैक्टीरियल इन्फेक्शन कैन अकर. So highest chances are with the bacterial infection. After bacterial infection is hepatitis B, which is transfusion associated hepatitis. Sir, मैंने आपसे क्वेश्चन में ये नहीं पूछा. See, I did not ask you that what is gonna be. The correct answer for this one is option number 2. In case somebody mentioned A, so I thought I'll just recreate that. Guys, I did not ask you transfusion associated hepatitis. I said transfusion associated infection. The commonest transfusion associated infection is bacterial infection. After bacterial infection, it is hepatitis B, which is to be remembered. Transfusion associated hepatitis is hepatitis B. Answer to question number 25 is Bombay. And apart from this, I have mentioned regarding the aspects, bacterial infection is more common than hepatitis B. Okay, guys, this is again a repeat INI-CET question. They gave an image of a person who was HIV positive and he was having these umbilicated lesions present. Maybe the CD4 count was also present, but that's not the case. I think everything is achievable. We all in third year feel like this. Things are not achievable, but हो जाता है somehow. When you get into that grind, तो प्रेशर में पढ़ते रहो रोज लाइब्रेरी में, हो जाएगा. Yes. हाँ, histoplasmosis आंसर आ रहा है सर. Umbilicated papules is not histoplasmosis. This would be disseminated cryptococcosis. प्लीज PYQs मेरे चैनल पे भी हैं. डॉक्टर मारवा लाइव वाले चैनल पे यू कैन गो थ्रू दैट ऑल्सो. द प्रीवियस ईयर पेपर्स आर प्रेजेंट. सो प्लीज पिछला वाला पेपर करके जाओ. पिछले 3-4 पेपर को आप सुन लीजिए ना, मेडिसिन सर्जरी के जो क्वेश्चंस हैं. सो आई थिंक यू विल बी एबल टू सॉल्व देम आउट गाइस. In a HIV positive patient, the lesions will look like that of, I mean, the lesions, I will write this. This is what my students told me, that sir, the lesions were resembles molluscum contagiosum. In case you have a lesion like this that looks like molluscum contagiosum in a HIV positive patient, do not answer it as, do not answer it as molluscum contagiosum per se. Answer it as disseminated cryptococcosis. Answer to this would be option number B. And then you can discontinue CD4 count. At what CD4 count should you discontinue fluconazole? If there is a cryptococcosis, the cutoff is more than 100. This again is a previous year question which is to be remembered कि CD4 count कितने के बाद में fluconazole stop कर देंगे. Cryptococcosis का treatment is gonna be liposomal amphotericin B plus fluconazole. Initially we'll give liposomal amphotericin B plus flucytosine. Then we give fluconazole, and then fluconazole is continued till how long? Till the CD4 count becomes more than 100 in a person. So that's again an additional fact which is to be remembered. A repeat PYQ is what I have covered here. And let's look at the last one for today. The question says, which of the following is, I've discussed about 30 odd images today, guys. I would like you to, I'll put this yeah, let's look at the last question for today. Which of the following is not required in the management? I've discussed about 30 odd images which I want you to go through, very spot on. ECG based CNS aspects I've talked about, couple of hemat issues I've tried to incorporate. So just go through those aspects so that you get a better overview. Just scroll through the PDF after that discussion is over, so that you are you are able to get an insight into how to rule out the options. Okay, guys, in subarachnoid, I think you can pick up the blood in the Sylvian fissure. And then you can also see blood not only present in the Sylvian fissure, but the blood is also present in the basal cisterns. That is the star of death coming up, no? Because there is blood in the Sylvian fissure, there is blood in the basal cisterns of the patient. So the diagnosis of this patient is subarachnoid hemorrhage. The one that you read with thunderclap headache and the worst headache of my life. The question says, which of the following is not required for the management of this patient? So option A says pneumatic compression stocking. Sir, any patient who's bedridden will have chances of development of deep vein thrombosis. Subarachnoid hemorrhage patient will be given strict bed rest. I don't want another berry on an alternative site to burst, or whatever has burst, they can be rebleeding also. Subarachnoid hemorrhage, you could be having a बेरी एनोरिज्म। इनफैक्ट इस बार नीट में था कि सीटी के बाद अगला टेस्ट क्या करेंगे, तो सीटी एंजियोग्राफी करेंगे। सीटी एंजियोग्राफी बिकॉज देयर कैन बी मोर देन वन बेरी एनोरिज्म दैट इज वेटिंग टू बस्ट। एक बेरी एनोरिज्म आज बस्ट कर गया, दैट सेकंड वन कैन बस्ट टुमारो। सो बिफोर आई प्लान अ repair, what we can do in the patient is a CT angio so that we can identify a unruptured berry as well. We will put pneumatic compression stockings because the person will be bedridden. The drug of choice for subrectal hemorrhage is nimodipine, that is okay. Esmolol will be used if BP is very high in these patients because a lot of these patients can be having concomitant hypertension as well. So if there is a concomitant hypertension, then to lower the BP, because otherwise the bleeding will increase. So in concomitant hypertension, I can be using a short acting beta blocker. हम फ्लूइड रिस्ट्रिक्शन नहीं करते, फ्लूइड देते हैं। बीपी शुड बी ऑन द हायर साइड इन दीज पेशेंट्स। इतना हाई नहीं कि ब्रेन हैमरेज हो जाए, लेकिन इतना हाई हो कि सीपीपी मेंटेन रहे। देयर इज अ बेसिक फार्मूला दैट आई हैव डिस्कस्ड, दैट इज सीपीपी इज अ डिफरेंस ऑफ मैप माइनस आईसीपी। Because there is blood in the basal system, so there would be an obstruction, there would be an obstruction happening to the flow of CSF, so ICP will rise. If ICP will rise, then what will happen to cerebral perfusion? Pressure कम हो जाएगा। I don't want that to happen. So to maintain the mean arterial pressure, I will be giving IV fluids to this patient. I will not go for fluid restriction. We give fluids to these patients to keep the BP on the higher side so that we can have a MAP that can counterbalance the ICP. Please do not misjudge my words. I'm not saying I want a high BP. I never said that. I don't want a high BP. I said I want to increase the MAP to counterbalance. I just want that much rise. सिर्फ उतना rise चाहिए that it counterbalances the rise of intracranial pressure in a patient. If you can balance out the two, you need to maintain a cerebral perfusion pressure of 60 to 80 millimeters of mercury. We do not go in for fluid restriction. We give fluid to in these patients. If BP is very high, 220 by 130, yeah, I will give a small. But I will not try to lower it from 160 to 120 because if I lower it, it will worsen the cerebral perfusion pressure. The correct answer for this question, the last one for today, is option number beta. In this image-based question, you have to pick up one, the presence of blood in the Sylvian fissure, the star of death, that is the blood in the basal cisterns, which is present in this case, and make a diagnosis of subrectal hemorrhage. So it was a two-step question, and then in the end, you have to pick up, okay, these are the steps which are to be done for these patients. Subrectal hemorrhage is quite frequently asked, so my request would be to listen to the SH video at 2x. I mean, it is hardly a 1 hour video. You will be able to do it in half an hour, the main video I'm talking about. And I think that, you know, if they put up a question on the diagnostics part or on the treatment part, you should be spot on because nimodipine सबको आता है, बट वो जो therapeutic treatment में बताया उसका ना, उसके basis पे you will be able to solve this question relatively better. So these are the inputs from my side for today, guys. Yes, we are trying to do a in this case we are trying to do a permissive hypertension, not hypotension. That's a separate concept that you put up. So thank you so much, guys, for your kind attention and hearing me out here. It's been great interacting with you, and my email ID is anyway given here, so you can drop me a mail. And thank you so much, guys, for the patience of coming over, listening to me here. And anyway, yes, Dr. Sub, we will be conducting a session for FMG as well. Lots of sessions planned up, so keep tuned in to the channel, and we are going to come up with a lot of data which is very important for your exam and would help you clear it in the very first go. That's the objective for all the exams. Thank you so much, guys. God bless you, and see you again on another session.